Hello guys and girls, myself Dr. Omkar Sangita Dilipra Sonone, and today we'll be discussing about some important MCQs from your autonomic nervous system pharmacology. So as we all know, ANS has always been a very important part of all the central board examinations, including your FMG exam. So please remember, this topic plays a very important role. Okay, I hope all these MCQs you have received in the Telegram group named AFMG for FMGE and you have gone through it. Now let's discuss these MCQs one by one, and in a retrograde fashion. Therefore, we'll be discussing these MCQs and also revising the ANS topic from pharmacology. So let's begin the session. But before beginning the session, I would like you to go through this quote which states, "You want to cry, let it out. You are stressed, work it out. You feel tired, grind it out. But one thing you cannot do is to quit." So please remember, you need to be persistent throughout your preparations now. Okay, don't dare to quit. Any issues that you face, don't hesitate to contact us at any point of time. So let's begin to the next session of Sparks, the MCQ discussion for ANS pharmacology. So before starting the actual MCQ discussion, I would like you guys to just know some few points about your autonomic nervous system, that is your ANS, okay, that are very much important to understand the pharmacology. So ANS is divided into two types of nervous system. First one being your PSNS, that is your parasympathetic nervous system, and second is your sympathetic nervous system. These systems are also known as parasympathetic, is also known as your cholinergic nervous system, whereas sympathetic nervous system is also known as your adrenergic nervous system. And why are these known as cholinergic and adrenergic? So please remember, it is due to the neurotransmitter which is secreted in these systems. So please remember, in parasympathetic nervous system, acetylcholine is the neurotransmitter which is secreted. Therefore, it is known as cholinergic nervous system. Whereas noradrenaline and adrenaline are the neurotransmitters which are secreted in cases of sympathetic nervous system. Therefore, it is known as adrenergic nervous system. The most important thing that you need to remember to understand these systems is, when are these systems activated? So please remember, the circumstances when the sympathetic nervous system would be activated is when you are in a fight, okay, with someone, or you want to run away from some condition, that is flight, or you are frightened of something. Okay, so please remember, the circumstances or conditions when the sympathetic nervous system is activated are fight, flight and fright. So for example, just an example to remember, that is whenever a tiger is standing in front of you, you want to run, you are very much frightened, you are sweating out. Okay, this condition is an example to remember your sympathetic nervous system. Whereas parasympathetic nervous system can be remembered by, on a Sunday, on a holiday, you are relaxing on your bed. This is the key word to remember your parasympathetic nervous system. Okay, so please remember. Before actually starting the ANS pharmacology, the most important thing that you need to remember is about your receptors. As receptors play a very much important role in pharmacology, all the drugs are playing in and around the receptors only, right? So let's discuss the receptors. They are according to the system itself, that is the cholinergic receptors and the adrenergic receptors respectively. The cholinergic receptors are further subdivided into two types of receptors, that is the muscarinic receptors and the nicotinic receptors. The nicotinic receptors are of two types. First are your NM receptors. M goes for your new muscles, that is your neuromuscular junction. Okay, NM receptors are located at your neuromuscular junction, whereas NN receptors are your neuronal receptors which are located at the ganglia. Okay, then the muscarinic receptors are further subdivided into three types, that is M1, M2 and M3. First important one is your M1 receptor, which is located in your stomach, and it leads to increased secretion of your gastric HCl. So please remember, M1 receptor will stimulate HCl production. M2 receptors, these are located on your heart. And on a relaxing Sunday, what should your heart do? It should just calm down. Okay, so what happens in parasympathetic nervous system? The heart rate decreases. Therefore, whenever the M2 receptors would be stimulated, there would be bradycardia. And lastly, the M3 receptors are present at various places, but the important ones to be remembered are your, first is your the smooth muscles of your urinary bladder. Whenever M3 receptors would be stimulated, there would be contraction of your urinary bladder leading to micturition. These are also located on your various glands, and whenever these receptors are stimulated, there would be glandular secretions. Therefore, okay, like lacrimation would be there would be gastric secretions. Okay, important one. And lastly, it is also located on your bronchus, causing your bronchoconstriction. It leads to contraction of smooth muscles, therefore it causes bronchoconstriction, and it is also located in eye. Then coming to your adrenergic receptors, which are broadly classified into two types, that is your alpha receptors and your beta receptors. Alpha receptors are of two types, that is your alpha 1 receptors and alpha 2 receptors. Okay, so please remember alpha 1 receptors and alpha 2 receptors. Alpha 1 are present on your blood vessels, and whenever these alpha 1 receptors would be stimulated, these would lead to vasoconstriction. These would lead to vasoconstriction, important one. Okay, and whenever the alpha 2 receptors would be stimulated, and these receptors, please remember, these are located at the presynaptic terminal of the neuron. Where are these alpha 2 receptors located? These are located on the presynaptic terminals of the neurons, and these acts as brake to the sympathetic nervous system. इनका काम क्या होता है? Please remember, these acts as brake. ये कंट्रोल में रखता है सिंपैथेटिक नर्वस सिस्टम को. Then coming to your beta receptors. Beta receptors are further classified as beta 1, beta 2 and beta 3 receptors. How many hearts does the human body have? So please remember, we have one heart, therefore beta 1 receptors are located on your heart. And in sympathetic nervous system, what the heart should do? The heart should palpitate. मतलब क्या होगा? There would be increase in your heart rate. So whenever beta 1 receptors are stimulated, there would be tachycardia. Then how many lungs do we have? 2 lungs. Therefore beta 2 receptors are located on our lungs, in the bronchus mainly. And whenever we need to run, there should be excessive respiration which is occurring. Therefore there should be bronchodilation. Therefore beta 2 receptors on the bronchus causes bronchodilation. And lastly, beta 3 receptors are also again present at multiple places, but the important one to be remembered is your adipose tissue. And whenever this beta 3 receptors are stimulated in adipose tissue, it leads to lipolysis for energy. Okay, moving further, guys, now I hope this all the receptors you have understood, and now the pharmacology would just run in and around these receptors now. Okay, let's begin. So the first question for you guys today is, a patient with benign prostatic hyperplasia was started on prazosin a week ago but does not want to take the medication as he experiences dizziness. He also gives a history of an episode of fainting when he got up from bed the previous day. Which of the following can be considered as an alternative in this patient? So please remember, before starting this actual discussion, let's see where prazosin belongs. Okay, so prazosin कौन से group से आता है? Let's see that. Okay, so as we'll study about alpha blockers first. Okay, so alpha blockers. Okay, alpha antagonists also they are known as. So alpha blockers can be further classified into alpha blockers which are non-selective and alpha blockers which are selective. So non-selective alpha blockers, the two most important are your phenoxybenzamine. Okay, phenoxybenzamine is the drug which is used in cases of pheochromocytoma to control hypertension. And second is your phentolamine. Phentolamine is used at multiple places, one of them being intraoperative hypertensive crisis in cases of pheochromocytoma. Whenever you are operating pheochromocytoma, the patient lands up in hypertensive crisis, then you will use phentolamine. It is also used in cases of cheese reaction, which is due to tyramine, and it is also used in cases of clonidine withdrawal. And what is clonidine? So please remember, clonidine is the alpha 2 agonist. We will study about clonidine withdrawal further. So phentolamine is also used in cases of clonidine withdrawal. Then talking about your selective alpha blockers. Selective alpha blockers, they can be classified as alpha 1 blocker and alpha 2 blocker. As we know, there are two types of alpha receptors. Alpha 2 blocker is yohimbine, which is not in clinical use, therefore not important to be remembered. Alpha 1 blockers are very much important. So please remember, the alpha 1 blocker, which are non-selective again, they are prazosin, terazosin, alfuzosin like drugs. Okay, and these alpha 1 receptors are further subclassified into alpha 1a and alpha 1b receptors. As we all know, alpha 1 receptors are located where? They are located on your blood vessels, but alpha 1a receptors are specifically located on your prostatic urethra, whereas alpha 1b receptors are located on your blood vessels. Okay, so whichever drugs will only block the alpha 1a receptors would dilate the prostatic urethra and lead to increased urine outflow. Okay, and these alpha 1a blockers are your tamsulosin and sildosin like drugs. These are your tamsulosin and sildosin like drugs. Okay, so now let's begin. Let's come back to our question. So what the question states, that a person is suffering from BPH. BPH is common in elderly males usually, as we all know, right? And it leads to constriction of your prostatic urethra, leading to impaired urine outflow. So therefore a prazosin is given, which relaxes the smooth muscles. Okay, So prazosin is given a week ago, but now the patient experiences dizziness and fainting. As we all know, a very characteristic side effect that is associated with non-selective alpha-1 blockers like prazosin is your postural hypotension. Okay, please remember either postural or we can state it as orthostatic hypotension. That is, whenever patient changes his position from supine to standing, there is fall in the blood pressure, which leads to this sudden dizziness, or it can lead to fainting also. So this is a case of postural or orthostatic hypotension, which is a side effect seen with prazosin. Now, as the patient is experiencing this side effect, we need to change the drug, right? And to change the drug, we cannot consider any other drugs from this group itself, like prazosin, terazosin, or alfuzosin, because all of them would lead to postural hypotension. So we need to actually look for a drug which selectively acts on the prostatic urethra. So which are those drugs? Those are your alpha-1A blockers. And these alpha-1A blockers are your tamsulosin and silodosin like drugs. They are actually considered in patients of BPH who are normotensive. Okay, so please remember the drug of choice. Okay, so the drug of choice for patients of benign prostatic hyperplasia who are not suffering from hypertension are your alpha-1A blockers like tamsulosin and silodosin. So the option, so the answer for this question is your option number B, that is your silodosin. So please remember, BPH normotensive individuals, drug of choice silodosin, tamsulosin. BPH in hypertensive individuals. Okay, so please remember, BPH in hypertensive individuals, then the drug of choice would be prazosin like drugs. Then the drug of choice would be prazosin like drugs, because here it would also help to decrease the hypertension, right? So BPH in normotensive, tamsulosin. BPH in BPH in hypertensive, prazosin. Prazosin is also used in cases of scorpion stings. Moving further, guys, now to our next question, that is your intracavernosal injection of phentolamine can cause priapism. Which of the following is used to reverse this drug-induced condition? So as we all know now, phentolamine is what? Phentolamine is a non-selective alpha blocker. Okay, so please remember, phentolamine is a non-selective alpha blocker, and this drug is used in cases of erectile dysfunction. This drug is used in cases of erectile dysfunction or impotency. Okay, what it causes? It causes the vasodilation of your penile vessels, and therefore this drug can be used over there. Okay, so it is used in cases of erectile dysfunction where it leads to vasodilation of your penile vessels, increased blood flow, and that can cause erection. But this can cause extreme vasodilation, which can lead to this side effect known as priapism. And what is priapism? Priapism is painful persistent penile erection which is lasting for more than 4 hours. This is a thing to be read in surgery. So please remember, priapism is nothing but a painful persistent penile erection lasting for more than 4 hours, and this can be a side effect of phentolamine due to extreme vasodilation. So now, which of the drugs can be used to reverse this condition? So please remember, as we have used the alpha blocker to reverse this condition, what we need to use? So to reverse alpha antagonistic action, we need a alpha agonist. So please remember. So now let's see in the options which is the alpha agonistic drug. Option A is phenoxybenzamine. This is your non-selective alpha blocker, again from the same group as phentolamine. This would rather worsen the condition. Next is your prazosin, which is an alpha-1 blocker, which is not indicated. Again, it would worsen the condition. Option C is your propranolol, which is a beta blocker, not indicated. And lastly, option D, that is your phenylephrine. And please remember, answer is option D, phenylephrine, which is a alpha-1 agonist. Okay, please remember, phenylephrine is what? Phenylephrine is a alpha-1 agonist. So that can be used to reverse the side effect which has been caused by phentolamine, which is a alpha blocker. So please remember, this is very much important. Okay, so you need to remember the agonistic drugs and the antagonistic drugs. That would make your work easier. Moving further to our next question, guys. The next question is, while performing fundus examination for a patient, when should atropine be substituted by phenylephrine? Okay, so let's start with the basics. What is fundus examination? So please remember, fundus is the visible part of the retina. Okay, so to see the fundus or the retina clearly, what we need to do? We need to dilate the pupil, right? So before any fundus examination or retinal examination, we need dilation of the pupil. Okay, dilatation of pupil is required, that is mydriasis. Dilatation of pupil is required, that is mydriasis. Okay, so the drugs used for dilatation of pupil are your anticholinergic drugs. Okay, and these anticholinergic drugs are like your atropine, homatropine, okay, which is a congener of atropine. Then cyclopentolate, okay, cyclopentolate, again an important drug. And lastly tropicamide. Okay, so please remember, the longest acting from this is your atropine and the shortest acting from this is your tropicamide. Okay, so these drugs cause mydriasis. Okay, these drugs cause dilatation as these are anticholinergic, right? So as they are anticholinergic, they cause dilatation of your pupil, that is mydriasis. So atropine is usually indicated for fundus examination in children. Okay, as it is long acting, its half life is more like its cycloplegic action is more than 7 days. Okay, and cycloplegia can lead to blurring of vision, okay, which can be actually adjusted in children, but it cannot be actually it should not be there in adults. Therefore, the drug of choice which is used for fundus examination in adults is your tropicamide, which is the shortest acting drug. So please remember, in children, the drug of choice for mydriasis is your atropine. In adults, it is tropicamide before a fundus examination is carried out. Okay, but what is the major disadvantage of using these drugs? So please remember, atropine, homatropine, cyclopentolate and tropicamide, all these drugs cause mydriasis, but along with that, as I've told you, they also have a inhibitory action on your ciliary body, which leads to the cycloplegia. Okay, that leads to the cycloplegic action, which leads to the blurring of vision. Therefore, in cases where we need to avoid cycloplegia, we need to find a substitute. To avoid cycloplegia, we find a substitute, and that substitute would be a drug like phenylephrine. Okay, so phenylephrine only causes mydriasis. Okay, so please remember, phenylephrine only causes mydriasis, it does not lead to cycloplegia. This question has been asked prior, so please remember, phenylephrine is a drug which only causes mydriasis without any cycloplegia. Let's see the options now. Option A, only cycloplegia is required. No, phenylephrine does not cause any cycloplegia. Option B, mydriasis is required without cycloplegia. Yes. So please remember, option B is the right answer. Whenever we require only mydriasis without cycloplegia, the drug of choice should be phenylephrine. Okay. So now, I hope you have understood this. It is very much important to remember these things. Okay. Moving further to our next question, that is, while treating a patient with acute myocardial infarction, you observe an abnormal rhythm on the ECG. Your senior tells you to administer atropine to control this rhythm. What rhythm could it have been? So please remember, first we'll talk about atropine now. Okay. So please remember, as we have discussed earlier, what is atropine? Atropine is a anticholinergic drug. Please remember, atropine is a anticholinergic drug which blocks all the muscarinic receptors. It blocks all the muscarinic receptors. Therefore, it also it also blocks the M2 receptors, and as we all know, M2 receptors are located where? M2 receptors are located on the heart. So as it blocks the M2 receptors, and normal physiological function of M2 receptor is bradycardia. So as it blocks the M2 receptors, it would lead to increase in the heart rate, that is tachycardia. So in which condition we can use atropine? So please remember, atropine can be used in conditions of bradycardia. So please remember, as we all know, acute myocardial infarction can just land up the patient into various arrhythmias. Okay, various arrhythmias. They can be either sinus or non-sinus arrhythmias. Okay, it can be just a sinus bradycardia, or it can be AV block, or it can be any other tachyarrhythmias. Okay, so please remember, after acute myocardial infarction, the patient mostly lands up into sinus bradycardia, and to just overcome this sinus bradycardia, the drug of choice for sinus bradycardia is atropine. So the answer over here is option C, sinus bradycardia. So please remember what the things are to be remembered for atropine over here. That is, the atropine is the drug of choice for bradycardia and AV block. The two important features about atropine over here are, atropine is the drug of choice for bradycardia and AV block, atrioventricular block. Important thing. Now let's see, we'll be discussing about atropine very frequently throughout the session, because atropine is a very important drug from ANS. Questions have been asked multiple times about atropine. Okay, so please remember this. Then your next question is, your senior prescribes clonidine to a hypertensive patient. Which of the following statements is not true about this drug? Okay, so as we have discussed earlier, what is clonidine? As we all know now, clonidine is a alpha 2 agonist. Please remember. So just we'll discuss about some alpha agonists which are important. Okay, alpha agonists which are important. As we have discussed about one alpha agonist that was important was your phenylephrine. And phenylephrine के बारे में क्या याद रखा तुम लोगों ने? So please remember, phenylephrine is a drug which causes mydriasis without any cycloplegia. It causes mydriasis without any cycloplegia. Okay. Then alpha 2 agonists are your clonidine and your methyl dopa, and these are the most important drugs to be remembered. Please remember. Okay, alpha 2 agonists are your clonidine and methyl dopa, which are usually considered in hypertensive patients. And rather, methyl dopa was previously considered as a drug of choice. Now it is not, but it was previously considered as a drug of choice for hypertension in pregnancy. So please remember, methyl dopa was prior considered a drug of choice for hypertension in pregnancy. Now the drug of choice for hypertension in pregnancy is labetalol, which is alpha plus beta blocker. Okay, so please remember, hypertension in pregnancy, abhi agar question pucha jaye, what is the drug of choice? The answer should be labetalol. Okay, please remember this. Very important question, repeated. So now, as we all know, alpha 2 agonist is our clonidine, which is used in hypertensive patients. And alpha 2 agonist kya karenge? They would act as brakes on the sympathetic nervous system. Okay, they would act as brakes on the sympathetic nervous system. They will stop the sympathetic nervous system. Okay, so let's see what are the statements given about clonidine and which one is not true. We need to find the incorrect statement. So option A, it acts on alpha 2 adrenergic receptors. Okay, right, it is alpha 2 agonist, it acts on alpha 2 adrenergic receptors. B, can result in rebound hypertension and abrupt withdrawal. Yes, this was the side effect that I was talking about prior. So please remember, clonidine, if after a prolonged use of clonidine, if clonidine is stopped abruptly, okay, it is stopped suddenly, then it can lead to rebound hypertension. Okay, it can lead to rebound hypertension, and this is a side effect seen after clonidine is abruptly withdrawn. Okay, so rebound hypertension is a side effect of clonidine, and for that the drug of choice we have discussed already. The drug of choice for clonidine withdrawal is phentolamine. Okay, so yes, the option B is also correct, that it can result in rebound hypertension on abrupt withdrawal. Next, option C, inhibits salivation. Yes, it inhibits salivation. Okay, it inhibits salivation. It has a inhibitory effect on your salivary glands. And lastly, option D, it can produce CNS stimulation. So please remember, option D is the wrong statement. Therefore, option D would be your right answer. It cannot produce CNS stimulation. Okay, it is a centrally acting anticholinergic drug. It is a centrally acting adrenergic alpha 2 agonist, but it does not produce any CNS stimulation. Okay, important thing. So what the things are to be remembered from this slide, that is the drug of choice for hypertension in pregnancy is your labetalol. Okay, important one. The other two drugs that can be used in cases of hypertension in pregnancy are your clonidine and methyl dopa. Okay, the side effect which is characteristically seen with clonidine is your clonidine withdrawal, that is your rebound hypertension after abrupt withdrawal of clonidine, and the drug of choice for rebound hypertension is phentolamine. Okay, these are the most important things to be remembered from this slide. Moving on to your next question, guys. Now, which of the following statements most appropriately describes the vasomotor reversal of Dale? Okay, so to understand the vasomotor reversal of Dale, we need to just know the basic phenomena about adrenaline. Okay, so as we all know, adrenaline is what? Adrenaline is a neurotransmitter which is secreted in your adrenergic or sympathetic nervous system. It is also a drug. It is also known as epinephrine. So adrenaline usually has a biphasic phenomena. Whenever adrenaline is given intravenously, whenever it is given IV, it would show a biphasic phenomena. ठीक है? Adrenaline acts on all the adrenergic receptors, that is alpha 1, alpha 2, beta 1, beta 2, beta 3. All the receptors adrenaline acts on. Okay, but at different doses, at different concentrations. So please remember, whenever adrenaline would be given IV, it would first of all act on your alpha 1 receptors. It would first of all act on your alpha 1 receptors, and it would lead to vasoconstriction. जैसे ही vasoconstriction होता है, there would be increased peripheral vascular resistance leading to hypertension. Okay, so the BP would increase. The BP would increase. But as the concentration of your adrenaline falls, then it starts to act on your beta 2 receptors. It starts to act on your beta 2, beta 3 receptors, which are located on your blood vessels. Okay, which are located on your blood vessels. And इनका काम क्या होता है? They relax your blood vessels. Therefore, this causes vasodilation. This causes vasodilation. Therefore, now it would lead to vasodilation, decreasing the peripheral vascular resistance and decreasing your blood pressure. So now this is the biphasic response of adrenaline which is seen. Okay, at initial dose, at initial concentration, it would lead to hypertension. Okay, not actually hypertension, but it leads to increase in blood pressure due to stimulation of alpha 1, and then due to stimulation of beta 2, it leads to hypertension or decrease in blood pressure. This is the biphasic response which is seen with adrenaline intake on intravenous administration. Okay, but now what happens if a alpha blocker would be given along with adrenaline? Okay, so please remember this, just focus. If we have given an alpha blocker to a patient, for example, prazosin is given. Okay, so when an alpha blocker is given to a patient, what happens whenever alpha blocker is given and followed by that adrenaline would be given to this patient? So now, as these alpha receptors are already blocked, does adrenaline would have an effect on the alpha receptors? No, right? As the alpha 1 receptors are already blocked by the alpha blockers, there would be no action of adrenaline on the alpha receptors. Therefore, all the action of adrenaline would be concentrated towards the beta receptors. So there would be no hypertension seen. There would be just a prolonged and a prolonged hypotension which is seen. There would be a prolonged hypotension which is seen. So please remember, this phenomena is known as vasomotor reversal of Dale. This phenomena is known as vasomotor reversal of Dale. Whenever we give alpha blockers followed by intravenous adrenaline, as the adrenaline cannot act on the alpha 1 receptors now, therefore it only solely acts on the beta receptors, causing extreme vasodilation and landing up the patient into hypotension, severe hypotension. This is known as your vasomotor reversal of Dale. I hope you guys have understood this. So now let's see the statements. Option A, stimulation of alpha 1 followed by stimulation of beta 2. No. Option B, stimulation of alpha 1 followed by blockade of beta 2. No. What we have seen, there is alpha 1 blockade and beta 2 stimulation. Then option C, blockade of alpha 1 followed by stimulation of beta 2. And this is what is the vasomotor reversal of Dale. So option C is the right answer over here. First of all, there is blockade of alpha 1 followed by stimulation of beta 2, which lands up the patient into extreme or severe hypertension. Okay, and this is known as vasomotor reversal of Dale. I hope this is very clear. Vasomotor reversal of Dale can be asked in the questions. It has been asked prior. Okay, moving further, guys, now to your next one. A patient presents to the emergency department. Before starting this question, I want you guys to just star mark this question as many times as possible, as many times. Okay, because this question has been asked multiple times in the examination. So the question is, a patient presents to the emergency department with diarrhea, sweating, excessive lacrimation and salivation. Okay, pulse rate is 110 per minute. His plasma cholinesterase level was 50 units per ml. Which of the following can be used to treat this patient? So now, first of all, come to a diagnosis. Okay, so let's see. Patient came in emergency. Okay, and the patient presents with diarrhea. That is, there is increased gastric motility. Second, there is increased sweating. There is increased lacrimation. There is increased salivation. That is, all the secretions are increased. Okay, so let's narrow down our thinking to ANS first. Now in ANS, which is the system that would be activated? So please remember this. Increased gastric motility and increased secretions are seen with, yes, they are seen with cholinergic system, that is your parasympathetic nervous system. So first of all, we know that this is a case of cholinergic system. Okay, so this is a case of some cholinergic poisoning. Okay, this is a case of some cholinergic poisoning. Okay, so now let's come to a diagnosis. Sometimes it is given that it is a farmer. This question was asked in the FMG June 2021 session recently. So sometime it is given it was a farmer who took some pesticides and then he presented with all these symptoms. So please remember, this is a characteristic case of OP and C poisoning, that is organophosphate and carbamate poisoning. This is a characteristic case of organophosphate and carbamate poisoning. So from a pharmacology point of view, what are OPCs? So please remember, OPCs are nothing but they are irreversible acetylcholine esterase. Acetylcholine esterase is the enzyme which degrades acetylcholine. ठीक है, वो acetylcholine को तोड़ देता है. Okay, just inhibiting its action. So OPCs are irreversible acetylcholine esterase inhibitors. Okay, they are irreversible acetylcholinesterase inhibitors. So they deactivate this acetylcholinesterase enzyme, increasing the acetylcholine level in the synapse. And as this acetylcholine level is increased, it leads to cholinergic crisis like phenomena. And whenever there is cholinergic crisis, all the symptoms of cholinergic systems would be there. That is your diarrhea, sweating, excessive lacrimation, excessive salivation, excessive secretions from all over the body. Okay, along with that there would be meiosis, pinpoint pupils would be there. This is a characteristic phenomenon which is present in questions most of the times. Okay, so there would be meiosis also described in the case. Meiosis would be there. Okay, pinpoint pupils. So now as we have come to a diagnosis that this is a case of organophosphate and carbamide poisoning, now let's come to the treatment. Okay, so now what would be the treatment? As this is a cholinergic poisoning, we need to counter it. Okay, we need to counter it with a anticholinergic drug. We need to counter it with a anticholinergic drug. So let's see. Okay, all these options, first of all, option A, neostigmine. Okay, so please remember, neostigmine is given in certain cases, but it is not used in cases of OPC poisoning. It is given in other poisonings like cobra bite. So please remember, neostigmine is a drug which is used in cases of cobra bite, also to reverse the skeletal muscle relaxant effect. Okay, next is option B, that is your atropine, and this is your right answer. Please remember, the drug of choice, okay, the drug of choice for OPC, that is organophosphate and carbamide poisoning, is nothing else but atropine. So the drug of choice for OPC poisoning is atropine. Rather, atropine is also considered as a life-saving drug in cases of OPC poisoning. Okay, important one. Okay, atropine is given intravenously 2 to 5 mg. Okay, so please remember, intravenous 2 to 5 mg is the dose of atropine in cases of OPC poisoning, which is repeated every 5 minutes. Okay, it is repeated in every 5 minutes until what? Until there are signs of atropinization. Until there are signs of atropinization. What is atropinization? Whenever these symptoms would be reversed, that is the atropinization phenomena. Okay, these symptoms would be reversed. Okay, so the most common sign, okay, that you need to remember, this question might be asked. So the most common sign of atropinization that we see for, okay, the most common sign of atropinization that we look for is what? It is your mydriasis. Now the patient has come to us in meiosis. As soon as we give atropine, we keep on looking for mydriasis. As soon as the pupils dilate, we can stop giving atropine. Okay, so the most common sign we look for atropinization is your mydriasis, whereas the most characteristic or the most specific sign that will tell that atropinization has occurred is your decreased secretion. When the secretions would be decreased, okay, that is an indication to stop atropine. That is the most specific sign. Okay, this is very much important. So now the next drug that can also be used in cases of OPC poisoning is what? It is your pralidoxime. So PAM like drugs, okay, or DAM, that is diacetyl monoxime, is also used in these cases. So PAM, pralidoxime is what? So pralidoxime is a acetylcholinesterase activator or reactivator, you can say. It is a acetylcholinesterase reactivator. So please remember, it reactivates the acetylcholinesterase enzyme which have been inhibited earlier by OPCs. So as soon as these acetylcholinesterase enzyme would be reactivated, it would actually degrade the acetylcholine which is there in excess in the synapse now. But this drug is not life-saving. This drug is not life-saving, neither it is your life-saving drug. Okay, so please remember, it is neither life-saving, it is not the drug of choice in cases of OPC poisoning. It is only a drug which can be given along with atropine. Okay, but the most important drug in cases of OPC poisoning is atropine. Moving further to our next question, guys, that is, a 45-year-old lady presented to the medicine OPD with complaints of muscle weakness and blurring of vision provoked by exertion. What is the drug that can be used in the diagnosis of this condition? So let's come to a diagnosis first. Okay, so a 45-year-old lady, that is a middle-aged female hai, okay, a middle-aged female presenting with muscular weakness which is progressive throughout the day. Exertion kab hota hai? Throughout the day, right? So as the day progresses, there would be muscular weakness which increases or worsens. So this case can give you a hint that this is a case of myasthenia gravis. So please remember, we have put a provisional diagnosis, a preliminary diagnosis, that is myasthenia gravis. Okay, we might have some differential diagnosis for this also. Okay, so with this particular information that we have in the question, we can just come to a provisional or a preliminary diagnosis, that is myasthenia gravis. Okay, so this is a middle-aged female with muscular weakness which progresses throughout the day. Okay, and this case can also sometimes talk about ptosis. Okay, this case can also sometimes talk about ptosis, or there would be a image of ptosis which is given, and ptosis is due to paralysis of your levator palpebrae superioris, LPS muscle की वजह से होता है. Okay, so please remember this. So this case is of myasthenia gravis. Now let's see what drug can be used in diagnosis of this condition. Now to come to a final diagnosis of myasthenia gravis, we need to do some test. We need to perform some test. Okay, and the test which can be performed, okay, the preliminary test is your tensilon test. This is a screening test used in cases of myasthenia gravis. Tensilon test. In this tensilon test, we use a drug. Okay, we use a drug which is known as edrophonium. So please remember, edrophonium is the drug which is used. Edrophonium is the shortest acting drug. It is very short acting with a half-life of just less than 5 minutes. Okay, edrophonium has a half-life less than 5 to 10 minutes just. Okay, so edrophonium is used. So now let's see, the answer over here is option B, edrophonium. But why is edrophonium used? Okay, so please remember, in a case of myasthenia gravis, whenever edrophonium is injected intravenously, then the symptoms would improve. Okay, so please remember, the myasthenia gravis क्यों होता है? Okay, so the basic pathology of myasthenia gravis is antibodies which are formed. Okay, there are antibodies which are formed against the neuromuscular junction. Okay, antibodies formed against the neuromuscular junction do not let the neurotransmitter act on the neuromuscular junction, which leads to the muscular weakness which is seen. Okay, as soon as we give edrophonium, which is a cholinergic drug, it is given intravenously, it leads to improvement of this muscular weakness which is seen. Okay, it acts on the receptors and it improves the muscular weakness. Okay, so that is the funda of tensilon test, which is used as a screening test in myasthenia gravis. But please remember, the investigation of choice in myasthenia gravis is not your tensilon test, it is your EMG. We tend to remember that the investigation of choice for myasthenia gravis is tensilon test. No, it is just a screening test. The investigation of choice is a single fiber electromyography, EMG, important one. Okay, and one more thing to be remembered about edrophonium, guys, that is, it is also used to differentiate. This question has been asked in FMG June 2021 session recently. So please remember, edrophonium is also used in cases of differential diagnosis of myasthenia gravis and cholinergic crisis. Okay, so if in cases of myasthenia gravis we give edrophonium, the condition would improve, the muscle weakness would improve. But if it is given in cases of cholinergic crisis, rather the condition would worsen. Please remember, the muscle weakness would rather worsen in cases of cholinergic crisis, because as we have discussed, edrophonium is a cholinergic drug. Already there is cholinergic crisis. If you give edrophonium, there would be increased cholinergic crisis which can worsen the condition. Okay, so please remember. So edrophonium is used in tensilon test as a screening test for myasthenia gravis. It is also used for differential diagnosis of myasthenia gravis and cholinergic crisis. And the investigation of choice for myasthenia gravis is nothing but single fiber electromyography. Okay, and the drug of choice for myasthenia gravis is pyridostigmine. Okay, it is your pyridostigmine. Neostigmine can also be given. So please remember, the drug of choice for myasthenia gravis is pyridostigmine or neostigmine along with atropine. And why is atropine given along with it? So please remember, we need the drug to only act on the NM receptors. But as we all know, pyridostigmine and neostigmine are non-selective, right? They will act on the NM receptors also, and they will also act on the muscarinic receptors. To just overcome the muscarinic side effects that can be seen with this drug, we need to give an anti-muscarinic drug, that is atropine. Okay, so that would be the treatment of choice for this condition, myasthenia gravis. Moving further, guys, now the next question is, propranolol can be used in all of the following conditions except. So as we all know, guys, propranolol is what? Propranolol is a beta blocker. So lol जिस भी drug के नाम में आता है, it is usually a beta blocker. So just few important things that needs to be remembered from beta blockers. Beta blockers I will cover in CVS. Okay, just important things that you need to remember about beta blockers over here, right over here, are the longest acting beta blocker. So please remember, the longest acting beta blocker is nadolol. And the shortest acting beta blocker is esmolol. So please important, Longest acting is nadolol, shortest acting is esmolol. Then about some water soluble beta blockers. Okay, so water soluble, we have discussed water soluble beta blockers would be excreted by the kidneys. So as these drugs are excreted by kidneys, therefore they would be contraindicated in cases of renal failure. So which are the beta blockers which are contraindicated in cases of renal failure? And these are remembered by the mnemonic ANS again, where A goes for atenolol, N goes for nadolol, and S goes for sotalol. S goes for sotalol. Important thing about sotalol to be remembered is it has the beta blocking effect. Along with that, it also has a potassium channel blocking effect. It also has a potassium channel blocking effect. That we'll see in CVS pharmacology. Okay. Now, coming to the question back again, propranolol, which is a non-selective beta blocker. Important thing about propranolol is what? It is a non-selective beta blocker. Okay, so it is used in conditions like option A, thyrotoxicosis. Yes, propranolol is used in conditions of thyrotoxicosis whenever there is hyperthyroidism. Okay, so thyrotoxicosis is an emergency of hyperthyroidism. Okay, so thyrotoxicosis, how does propranolol acts? It inhibits the peripheral conversion of thyroid hormones. As we all know, so thyroid hormones are of two types, right? T3 and T4. Okay, the abundant form is your T4, that is thyroxine, but the active form is your T3. Therefore, whenever the thyroid hormone needs to act, it should be converted to T3 form. So this peripheral conversion of T4 to T3 would be inhibited by propranolol. Therefore, the thyrotoxis can be encountered by propranolol. Okay, so it can be used in cases of thyrotoxicosis. Second is your variant angina. Let's come to this after some time. First, we'll discuss about other topics. That is option C is your migraine. Yes, propranolol is used as a therapy in migraine also. Okay, it is used. Beta blocker therapy is used in cases of migraine. Okay, drug of choice for migraine are rather your sumatriptans for chronic migraine, but propranolol is used as an adjunct therapy. And option D is your hypertension. As we all know, definitely beta blockers are used in cases of hypertension. Okay, they are used in cases of hypertension. But the one thing that where propranolol is not used, okay, the one condition where propranolol would be absolutely contraindicated is your variant angina. It is your variant angina. Please remember, variant angina is also known as your Prinzmetal angina. It is also known as your Prinzmetal angina. It is also known as a Prinzmetal angina. Also known as your vasospastic angina. ठीक है, इसमें क्या होता है? There is spasm. There is sudden spasm of your coronary blood vessel. Okay, and therefore propranolol can rather worsen this condition. Therefore, in cases of Prinzmetal vasospastic angina, propranolol or any other beta blocker would be absolutely contraindicated because it would further cause ischemia to the myocardial tissue, landing up the patient into myocardial infarction, and therefore propranolol is contraindicated in cases of variant angina. Whereas let's see the uses of beta blockers. Okay, let's see the uses of beta blockers now. Okay, beta 1 blockers and beta 2 blockers can be used. Okay, beta 1 blockers, they are used in cases of hypertension, beta also in cases of classical angina. Okay, so please remember, in cases of classical angina, beta blockers are indicated, but in cases of Prinzmetal angina, beta blockers are contraindicated. This is very much important. Next, in cases of myocardial infarction, again beta blockers are indicated. In cases of chronic CHF, that is chronic congestive heart failure, beta blockers would be given. But in cases of acute CHF, beta blockers are contraindicated. Okay, in cases of acute CHF, beta blockers are contraindicated. Next, in cases of arrhythmia, beta blockers can be given. Arrhythmia. Okay, important one. This was about your beta 1 blockers. Beta 1 blockers. Let's see about beta 2 blockers. Okay, few important points about beta 2 blockers. So beta 2 blockers would be used in cases like glaucoma. They are used in cases like glaucoma to increase the trabecular outflow. Okay, as we all know. Next, they are also used in cases of anxiety. Okay, they would decrease your tremors which you have. Okay, they are also used in cases of tremors or in cases of anxiety. Okay, they are also used in cases of migraine. As we have all seen, they are also used in cases of migraine, and they are also used in cases of the last condition, that is thyrotoxicosis. So important one, the uses of beta blockers are important to be remembered. Beta 1 in hypertension and classical angina, MI, chronic CHF and arrhythmia. Beta 2 in glaucoma, anxiety, essential tremors, migraine and thyrotoxicosis. Okay. Now let's move on to our next question, guys. That is, all of the following are adverse effects of selective beta 1 blockers except. Okay, so let's see now. Beta 1 blockers, as we have studied about the receptors, this is very much important. This is why I was asking you to be well acquainted with the receptors now. Okay, so beta 1 receptors are located where? We have one heart, therefore beta 1 receptors are located on the heart. We have two lungs, therefore beta 2 receptors are located on the lungs or in the bronchus. So please remember, so beta 1 blockers would cause blocking action on your heart. So which would be the side effect seen when the heart is blocked? Let's see. Option A is your bradycardia. Yes, beta 1 blockers can lead to bradycardia. Option B is asthma. Let's come to this option again. Let's see first this option C. Option C is AV block. Again, option AV block can be associated as a side effect with beta 1 blocker. And last, option D is your acute congestive heart failure. Yes, acute CHF is also a condition which is a side effect of beta 1 blockers. That's why beta 1 blockers were absolutely contraindicated in cases of acute CHF. We have seen earlier, right? So please remember, beta 1 blockers के साथ the side effects of bradycardia, AV block and acute CHF. So the answer over here would be option B, asthma. Asthma is a side effect which is associated with beta 2 blockers. Okay, beta 2 blockers के साथ side effect क्या है? Asthma. It causes bronchoconstriction and therefore the answer over here would be option B, asthma. So let's see about the side effects. Side effects or adverse effects of beta blockers are very commonly asked, and those can be remembered as A, B, C and D. Okay, where A goes for AV block. A goes for AV block. Also for asthma. So beta 1 blockers are contraindicate. Beta 1 blockers can lead to AV block and beta 2 blockers can lead to asthma. B goes for bradycardia. C goes for CHF. But which type of CHF? Acute CHF. So please remember, beta blockers are indicated in chronic CHF but contraindicated in acute CHF. And lastly, D goes for diabetes mellitus. Okay, as we all know, this question has come earlier. Why are beta blockers contraindicated in case of diabetes mellitus? So please remember, important thing is they mask the hypoglycemic symptoms. So whenever a diabetic individual, whenever he has taken insulin, he experiences hypoglycemia, it gives us some warning signs. Okay, it gives us some warning signs. The patient feels giddy, there is dizziness, there is there is sweating. All these are your warning signs or hypoglycemic symptoms which are seen in diabetics. But if we give beta blockers, all these warning signs or hypoglycemic symptoms would not be seen. They would be masked off, and therefore the patient can literally collapse. Okay, that is the reason why beta blockers are contraindicated in cases of diabetes mellitus. They are also contraindicated in one more condition, that is your PVD, that is your peripheral vascular disease. Okay, like Raynaud's phenomena, they are contraindicated in those also. Okay, so important one. Just the last point that I need to mention over here is about your beta 2 agonist. Important drugs, therefore. Okay, the last point is about beta 2 agonist. And what are your beta 2 agonists? As we have already discussed, beta 2 receptors are located where? They are located on your bronchi. They are located on your bronchus. So beta 2 agonist would lead to stimulation of your bronchus. They would lead to relaxation of your smooth bronchial muscles, and they will cause bronchodilation. Therefore, bronchodilation is required in cases of asthma, right, or in cases of COPD. So please remember, beta 2 agonists are the drug of choice in cases of acute asthma or in cases of COPD. And beta 2 agonist drugs are your salbutamol. Shorter acting are your salbutamol like drugs, and longer acting are your formoterol like drugs or salmeterol like drugs. Okay, important one to be remembered. Okay, salbutamol and terbutaline are shorter acting, formoterol and salmeterol are longer acting beta 2 agonists used in cases of asthma and COPD. Important ones. Okay, so this was about all your ANS, guys. Thank you so much for attending the session throughout. Okay, I hope now ANS has been simplified for you. Okay, that chart that I have given you earlier in the first slide itself, that is very important to be remembered for understanding all the ANS pharmacology. If you have any issues, any problem in this ANS pharmacology, you can drop the queries in your chat box, in the comment box in the below this video, or you can also ask the doubts in our AFMG Telegram group. Okay, I'll be more than happy to assist you all, okay, in any of your queries. And Thank you so much, and let's meet again soon in the next session of Sparks.